Today we're talking with Dr. Victor Czerkasij about prior authorizations, tips and tricks. Dr. Czerkasij is a DNP at Skin Cancer and Cosmetic Dermatology, faculty at Vanderbilt University, and an associate lecturer at Fitzgerald Health Education Associates. Welcome to the Nurse Practitioner Podcast, Dr. Czerkasij.
Thank you so much. Happy to be here. By the way, it's my birthday.
Well, happy birthday. Well, go ahead and dive into prior authorizations. Patients and providers generally follow a common pattern when they meet together over a visit. Tell me how that works for you, and where do you find the most frustration?
Well, thank you for asking about both patients and providers. There is a common pattern. When you yourself go to see someone like myself, you expect that the encounter will be safe. We know that it will be efficacious if there's medication that's provided, and hopefully it'll be durable. And finally, will you be able to get it? How many times have our listeners heard from their patients when they come on follow-up? Well, I didn't get everything you prescribed me because I couldn't afford some of it, or it was way too expensive, or my insurance declined it. So that common pattern across healthcare in America has been particularly frustrating for myself, and I know many others. And I mean, when I talk about these four criteria of a successful visit, let's look at the first one. It's safety, right? So we definitely want to make sure that that product fits that area and efficacious. So I can give a patient, if they have atopic dermatitis, a glass of water. It's certainly safe, but it's not efficacious. And then, of course, durable. And we have many, many medications out there today. We're in the golden years, particularly in dermatology. But these golden years cost gold. They're very expensive as well. And there is a disconnect between insurers that I'd like to talk to our audience today and patients and providers who have certain expectations. So that's really where the frustration is, especially.
So you mentioned access as the greater challenge among providers today. Can you describe a little bit more about how that has come to pass in healthcare today?
Yes, I would like to talk about that part. And access has a lot to do, if not everything, with the, 500-pound proverbial gorilla in the room. They're not there, but they are one of our biggest influencers, and that is the insurance company. They are the ones that are going to direct a lot of our treatment. For example, I take Medicaid. I take Medicare. I take commercial insurance. I take also people who don't have any of that. They're cash pay. And that is, unfortunately, going to direct a lot of my attention. For example, let's say someone is cash pay. Well, it does no good to write very, very expensive medications. We can try, but, they don't have someone on their side, so to speak, because they're all alone. So, of course, I always look for over-the-counter products as well. By the way, not to go down a rabbit hole, but there's no specialty that writes, so to speak, more medications or directs people to over-the-counter than dermatology. We have a huge amount available that used to be a prescription product. You can only write it by seeing an authorized DEA licensed provider. But now it's become over-the-counter, so that has been a big help. But going back to your original question about the access issue. So, yeah, that is a huge area. We could write all day. I can do it. I see 50 to 60 people a day. And I could easily make almost every person better with what we have available, with the conditions that are out there and the medications, but they tend to be very expensive. And that's a problem for insurance companies also. They're trying to limit costs. Also, many of them are publicly held, and so they have responsibility to their shareholders as well. What's interesting, again, one interesting little rabbit hole is if you look at the annual top 100 most influential people in healthcare these days, there is a listing that comes out, and I think it's done by Healthcare Association, just doesn't come to me at the moment, but the top 50 includes not a single provider, not a single person that is actually seeing patients. It's all politicians, it's all insurance bigwigs, it's all venture capitalists, it's all inventors of particular medications, but you'll be hard-pressed to find anyone who's an actual provider. So we are on the end of the spigot getting a few drops of help, and it becomes a real challenge. And that's what's occurred in healthcare today. We just have a huge disconnect between what we ethically, morally feel we can do for our patients at that front line but we don't have it until you go through a walk of shame, which I'd be happy to explain a little bit more.
Thank you for explaining that. What are some of the specific questions that should be asked of a specialty pharmacy? Are you asking them as a provider, or is it the work of a biologic coordinator? And what is the history of that position?
Well, that is a really good segue to what I just mentioned I'd like to talk about, which is the history of where we've come through this walk of shame, as I call it. So it's called step therapy. Step therapy has been what's developed, particularly in light of the more expensive biologic medications. We've had an enormous, leap of medicine and education and technology when it comes to serving our patients all across the different specialties. And that is the biologics, which are extremely effective, targeted medications that allow us to have a very minimal side effect. Take, for example, psoriasis. In the past, all we had were immunosuppressants and steroids, and neither one of them is a really good answer for a chronic condition that is not curable, right? Kimberly, you can't put someone on a lifetime of immunosuppressants or medications that are just like steroids. Steroids are one of the great inventions of the 20th century, no doubt about it. But yeah, you just can't do that. That's so many severe side effects over time. Biologics are wonderful because they have very limited side effects that are hugely acceptable over what it was a generation before. And they have great results because of the targeting. They specifically only hit in the body the one protein, or cytokine we call it, that starts the trouble regardless of the condition in the body. But going back to specialty pharmacies, and we need to show now, based on what's developed, which are rules that the insurance companies have come up with, so to speak. You're hard-pressed to actually find that, but to save costs, they have what's called step therapy, or as I call the walk of shame, because you could have someone come in and they're really hurting and they need help. And I say to them, well, listen, looking at your insurance, and I won't name any right now, just so we don't argue, but it's the majority of insurance companies that people choose to have or are required to have, and that includes Medicare and Medicaid, not just the commercial. They'll say, well, there's cheaper options. Well, cheaper oftentimes is not more effective. Remember, we talked about safety, effectiveness, and durability. And they may not be safe either. That's another problem. I'll talk to the insurance company and say, now, wait a second. It can help them, but it could also make them violently ill. Well, yeah, but it might not. And I'm like, well, wait, what if it does? Then do you put your name to this? No, that's you as a provider. Well, that's really a big problem, because we all also are aware of another gorilla in the room, and that's lawyers. That's something we all get sued at one time or another in a career. I think it's expected that every single provider will have at least one lawsuit against them, and usually it's harm. But what if you were in the service of that person and you were following the insurance company protocol? Well, they'll let you twist in the wind unless you really, really put out the fight. So what's happened now is we have these specialty pharmacies that help us go through this maze that has been created predominantly by the insurance industry themselves. And by the way, how much am I compensated for all my time that I spend with specialty pharmacies on behalf of my patients? What is the ICD-10 code for my time, which is valuable? I could be seeing patients. Zero. Nothing. They set that up. And we have to spend a lot of resources. We have to hire biologic coordinators that work with these specialty pharmacies to get these very expensive but effective and overall safe medications. So that's what a biologic coordinator does, if you can afford one. That's been the history of the position, is it came up thanks to the insurance industry themselves. And the questions that they're going to be wanting to know is, did you get the right code? Did you, in fact, try these other medications? Can you document what they've done in the past? And can you tell us how long you've used these medications? So it takes a huge amount of coordination and time at the end of the day.
Are there benefits that outweigh not using a specialty pharmacy? Couldn't you just do this on your own?
Well, let's answer this by telling you approximately 9 out of 10 insurance plans today will manage these medications through the step therapy or limits on a drug quantity. But by doing that, they are asking that you will be filing these forms and faxes and emails and documentation. And that basically could take my whole day when I'm expected to see patients. That's what we were made to do. It's like taking a racehorse that wins races, right? That's what I am. I am the racehorse that the jockey rides and gets to the victory. Yay, every day we win the race. And then you say, but also we want you to go out in the field. We're going to hook you up to an ox and you're going to go ahead and pull a plow all day long in the heat. I mean, you got to do either one or the other. So what we've started to do in our own office, this is a really good tip, and others have done this too, is we will interview these specialty pharmacies themselves through our biologic coordinator. And we will find the ones that are saying, hey, listen, all you got to do is give us access to your, following HIPAA rules, to your patient notes and everything that you can document for us. We will coordinate the prior authorizations. We will do the appeals. We're familiar with the companies that have these drugs, their bridge program, their copay program. We can talk to you about Cigna. We can talk to you about Blue Cross. We can talk to you about Medicaid, Medicare. We know these programs. And so by interviewing these companies and asking them, will you cover in our specific area what commercial plans you coordinate with? And could you give us someone as a point of contact? Kimberly, I think this is a wonderful tip. This is a pearl to anyone listening, is when you have your biologic coordinator or whoever is responsible in the office for dealing with the specialty pharmacy, give me a name. Give me a couple, 3 names in case someone goes on vacation, and they'll know us and they know how we practice. They know what I write. I mean, there's one product, a biologic. I have 3,000 patients on that one. So you can imagine they want that kind of business, because that keeps them busy as well. And there is something that is provided for them. That's how they make a living. So they give us a pharmaceutical hub, and they work with us on our electronic medical records. And doing it on your own, I just couldn't. Going back to the racehorse analogy, it's just way too much work. By the way, I'm sorry, I have so much to share with you. I might mention that they have just created, it's actually the National Eczema Association is trying to get through Congress the Safe Step Act, which basically says, listen, while patients are suffering, and I mean suffering, they are hurting, they are not able to go to work, they're getting infections and different diseases while they're waiting to get approved the good medicine. The Safe Step Act, I even have it written down here, HR 2630-S. How about that? They're trying to get it so that the insurance companies do not put people through the kind of misery that they're able to do sometimes, whether by plan or accident. Some people by years. They could be waiting a couple years. We have some prescriptions that I can write that are called Cover Until You're Covered. Basically, the company, the pharmaceutical company that everybody likes to say terrible things about in society, listen, they'll do something called Covered Until You're Covered. We will give you the medicine for your patient for up to 2 years while we're going through all this paperwork. But, sadly, sometimes while you're going through the paperwork, a person might change their insurance or lose their job or get married, and everything has to start all over again. So, Kimberly, I know I'm talking a lot, but it can be a really frustrating place to be for us providers on the front line.
So here we have a provider listening to this podcast and thinking, this should be easy. Prior authorizations can't be all that bad. What if the medication has still not been approved or has in fact been rejected? What are the common reasons for insurance rejections of a medication that you've prescribed?
Yeah, so if there's somebody that's really that confident, I'm glad for them. And, before I answer that question, I have to tell you a quick story. You mentioned Vanderbilt University at the beginning. And I did, in fact, get my master's from there, and I'm a faculty right after I graduated. One time they asked me to come up and lecture like I will be doing in a few weeks every semester. And I stood up, and usually it's standing room only because a lot of people come in from other specialties and they want to hear how, as I explained dermatology, whatever the topic is. And one time I stood there and I said, listen, young people, ladies and gentlemen, I just want to tell you that I had a great experience here at Vanderbilt. But they failed me. They failed me in one area, and everybody was like, the faculty are shocked that first time, and everybody's going, wow, this is going to sound dramatic. And I said, they teach you how to assess. They teach you how to diagnose, and they teach you how to prescribe while you're in school to be a nurse practitioner or PA. But the one area that they completely fail you is how to deal with insurance companies. And that is totally on-the-job learning, and it's so frustrating. So here you have this provider that you just told me that's listening, thinking, it should be easy. They can't be all that bad. Well, I mean, if it's approved, great. But what if it's not approved? And all of a sudden you get thrown all these faxes and emails, and your biologic coordinator is coming to you twice in one day and saying, hey, listen, this isn't good enough. You're going to have to get this other medicine. Kimberly, I will have every week where I write a prescription. It's rejected by the insurance company to pay for the patient. And then I say, well, what's the recommendation? So they say, oh, you have to do this cream instead. Okay, so I write the cream. Guess what? The insurance company says you have to do a PA for that one too. At that point, if the windows weren't permanently locked on our third floor office, I would have jumped out. I mean, I just pull my hair. I'm like, did you just do this to me? You declined this one and said I have to do this other one. Okay, so I do the other one, but you're also declining that one as well. And I promise you, I have a feeling that they are just laughing behind the scenes, wondering to see how far I'll fight for my patient. So what do you do if it's been rejected? What are some of the common reasons? Okay, I'll give you reason number one. Here's number one. Why it might be turned down. Do you have the correct ICD-10 code? Are you diagnosing this condition somehow else? Like, for example, I'll go back to psoriasis, since that's a real common one for me in derm. I write plaque psoriasis, right? But someone says their patient's not getting covered. I go, what did you write? Oh, I wrote inverse psoriasis, or I wrote guttate psoriasis. I go, well, the medicine that you're writing doesn't cover inverse or guttate psoriasis. It has to be plaque psoriasis. I'm not going to tell them to lie or cheat and then fake it, but you got to have the right ICD-10 code, number one. Number two, what is the patient medication history and length of their journey? Have they tried these other medicines long enough? Now, if someone says, I've been doing 10 years of steroid, triamcinolone, clobetasol, twice a day for months on end. Yeah, that's most likely going to get covered very easily. What if they're pregnant? What if they have hepatitis? And the medicine the insurance company wants you to go on is not fit for a woman who is expecting, nor a person who has hepatitis, right? Liver disease. So you have to have clinical justification for the particular medication with that disease. Do you have the updated labs, right? Here's an interesting conundrum, and I want everyone to know this. Many, many medicines that are biologics in particular, and I'm picking on that class because that is the classic area of prior authorization problems, but it could be any one. But they require a quantiferon or a PPD to determine that they are negative for tuberculosis. Great. The package insert says you only have to do it one time and you don't have to ever do it again, just the first time. And then you can go 10 years on that medicine. But the insurance company may require annually a quantiferon on their own. Drug company can also say you don't have to see this person but only once a year. Making this drug once a year be fine. But the insurance company requires that the patient come in every 3 months or 6 months. That's to keep the patient honest and to make sure they're actually coming in and getting a benefit, and we can document that. So you have these two conundrums, or let's see, what's the word I'm really looking for? English was not my first language, but dissonance. Yeah, there's a dissonance. So between even package insert, which you're supposed to follow like a Bible, or, what the insurance company requires. So find out. Let's see, what else can I come up with? Oh, yeah, the chronic conditions. Oh, why, in your professional opinion, is this medication necessary? And I always come up with a pithy phrase that says, they already tried everything that is approved, and this is the only one left, and it is, in fact, FDA approved for this condition that I've written. The other thing is I also try to use different quality of life things. For example, what is their profession? What's the emotional impact, their daily activity on their life when they suffer from this disease, this condition? Do they miss a lot of work? Are they not able to progress? Are they not able to have an intimate relationship with anyone as a result because of the pain in that area? Classic example is some drug companies will say, we will not cover this medicine unless that person who has an insurance plan with us has at least 10% of their body covered, right? And then at 10% or higher, we will pay for it. Well, I say, no, you're right. They don't have 10%, but they have 3% between their groin and their axilla. Well, I'm going to tell you something. Those are really sensitive places. And I have a really hard time having a drug company try to be mad at me for getting it covered in those very sensitive areas. I mean, it's hard to live your life because it's not comfortable at all. So to answer again, what are some of the common reasons for insurance rejections? Those are, I think, the major ones.
I've heard that AI can be of help in the approval process. Have you had experience with AI, and where would this technology fit in when making an appeal?
Okay, so you heard right. AI can be of help. And I was ashamed the first time I thought about doing it. And I'll explain. My whole life, am original, right? I've written some books. I have a lot of articles and research, and it's all from my experience. I sit down, it's hard work, and I write these letters back to the insurance companies, and it takes time trying to fight on behalf of my patients, being a good advocate, not just a provider. Well, some months ago, it kind of was in a conversation and it hit me where someone was telling me about another thing where you can pre-populate using ChatGPT or other famous groks and things like that. You can tell I'm old. I don't know them all. They said, just put all that information in there and see if it pops out with something that you'd like. And lo and behold, I have been writing some of the most remarkably cogent and effective letters on behalf of my patients, as well as getting our medical assistants and our biologic coordinator doing the same. And they include all kinds of great references as to why we should not be using these other medicines that the person has had over time, which have been very ineffective and somewhat dangerous to their health over time. And wow, AI letters come out really polished, and I'm not ashamed at all. I think it's a clever, helpful way to advocate for our patients. And it's just a really clean letter, and I sign it, and off to the races we go. So I think when you're writing appeal, I think this technology is a wonderful place for it to be of use. In fact, let me just add that maybe you should consider your office paying for subscription so you can be doing this all the time.
That's a great idea. Could you explain the phrase peer-to-peer? What is it, and do you have any experience with it?
I do. And by the way, I should probably mention one more thing that came to mind. You can find letters, we call them LMNs, and this is in the business with prior authorizations. There are samples of letters of medical necessity that are available online, and they are non-proprietary. You can also find letters of exception where it says, I have a few medicines that I use that are outside the usual coverage, and they're orphan diseases, but it documents your thinking. And yeah, so letters of medical necessity and also the letters of exception as appeal letters are very helpful. But your question again was explaining peer-to-peer. Okay. So there are professionals like myself who were providers at one time that now work for insurance companies. And what they do is they evaluate these letters of medical necessity or of exception as an appeal, and they will then write back also, probably using AI. I don't know, but they're also writing back a letter to me saying, okay, you've made your case and we will cover it for the next year, the next 2 years, as long as they come in every 6 months, or we'll revisit this issue over time, but we'll go ahead and do it. But they will also say, we would like a conversation with this person, this provider who is fighting on behalf of this patient. So again, more time at the end of the day. So you schedule either at lunchtime I do, or at the end of the day, a peer-to-peer. And I only do this once or twice a month. It's not that much, but it's a little stressful for me. And my tips and tricks for a really nice peer-to-peer discussion regarding this patient is be nice. Really, I just express myself right at the start and say, thank you so much for taking the time to speak with me regarding this mutual patient. They're, of course, someone that has chosen your insurance and you're covering them, and I'm doing the best I can. I'd like to review the journey for myself as a provider, and I know that you've been doing this also. Can you tell me a little bit of your background, I'll say? And sometimes they're very nice, and they'll say, well, I also worked in dermatology, or I've worked in primary care. And all right, well, let's review your denial letter to me, I'll say. Help me understand point by point why you're declining this and how I can improve. What do I need to do to be of service to both you and our mutual patient? So I try to reframe the objections that they have in a really polite way. And I then say, give me the specific things I need to do to get this medicine, and I'll write this down. I get their name and I hold them to it. So we will do that. And I think that they've been yelled at enough in life. I don't think that's ever professional. I don't call people names. I don't yell. I don't raise my voice. I try to be cheerful. I know they're tired. They've got other people to call. I'm not that person. And I think that that's just the more professional way to be, is to be kind, but be firm and know ahead of time what you're going into. Expect the questions they might ask. So that's my experience with peer-to-peer. And you can request that, by the way. If you're not getting anywhere with your patient, you can request that.
Finally, what should our listeners pay attention to most in prior authorization work?
Well, that's a good summary question, Kimberly. And I would say the most important is, again, a history of the patient and provider journey. What are the medications that have been used in the past for this condition? Make sure that the condition that you're treating, in fact, has a ICD-10 code that has a medication that also is approved for that ICD-10 code. That point right there is huge, because then you have a match. If they ask me to do an immunosuppressant, I can reply and say, I'm sorry to point this out to you, but you're asking me to do something that is frankly illegal. You're asking me to use a medication that was never approved for this condition, like steroids or immunosuppressants. I know that traditionally we've done that, but now in light of the FDA having an actual approval, I think we need to stay in the lane. And I said one time, this is only one time that I've done this, where I asked the doctor in the peer-to-peer, who was really pushing me to write this immunosuppressant for a younger child, and I said, listen, okay, I see that I'm not getting anywhere with you, but I'm going to go ahead and write your name down on this as well, and I want to send it to you for your signature as you're telling me to do this. And we're going to both take responsibility for this medication. He goes, I can't do that. I said, why not? He goes, well, there could be a pretty bad side effect, and I don't want to be responsible. And I said, now you know exactly how I feel. And there was silence on the other end of the phone as he thought about that, and he's like, all right, we'll do it. And I said, thank you. I said, I appreciate that. He didn't want to take responsibility either. But I wanted them to go on record as the insurance company, and I needed a name that they, in fact, were going to take part of the hit if there was one coming with that child. I was never going to do it. I'm going to be honest with you. But I needed to really put his feet to the fire. So the ICD-10 code, making sure that it's an FDA-approved medication, having that history. And, the other thing is make sure that so you don't have that kind of problem in the future as you document the person coming in. List how clear they are. List what the side effects are, if there are any. Usually there's none. Patient is happy. They're at work. They express that they now, don't have to use so many other medicines as well. Quick example. Hidradenitis suppurativa is a brutal condition that affects primarily Black women, and it could really cause pain and scars and odor, and just life is not easy to live with this horrendous condition. Well, I was there when we had nothing. We had antibiotics, steroids. We had metformin, spironolactone. We had topicals. We had washes. We had creams. We had Accutane we were even using. I mean, we had these cocktails of medication, and they were coming in every 6 weeks to 3 months and just not getting better, just doing the best we could with all that we had. Well, guess what? Now we have 3 FDA medications. Each one of them is an injection that you take once a month or once every 2 months. And the person comes in every 6 months. They don't have to be on all those cocktails of medicines. They're happy. They're better. They're contributing to society. They're paying their taxes. They don't have to be on Medicaid, some of them. They now moved off from Medicaid and they have commercial insurance because they have a job. That medicine is saving our society money. And people don't have that pain and anguish and suffering. They don't have to come in so much. I'm happy because I'm not suffering either, watching this person getting the runaround when we had nothing available. I felt terrible. We were trying to juggle 15 balls, and I'm not a juggler. So now today, I really think that some of these medicines are lifesavers. And in the end, these very expensive inflammatory conditions can be treated reasonably with the medicines out there if we are the smart advocate on behalf of our patients.
Dr. Czerkasij, this was very informative. Thank you very much for speaking with us today.
It's been a pleasure and a privilege.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal and on X at TNPJ_journal. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Thanks for listening.